we're lucky enough today to be joined by Dr. Grace Swart, who's a neurologist with expertise in neuroimmunology and neurophysiology, who's currently working over at the Brain and Mind Centre in the University of Sydney, but is apparently about to head off overseas to the Mayo Clinic. So we wish her all the best with that. But in the interim, she's going to be talking about the very relevant topic of nitrous oxide-induced myelo-neuropathy, which may, I'm aware we have quite a cross-section of people in the audience, and certainly something we see quite a lot of in and around the inner city, but perhaps not quite as prevalent out in the communities. But there's increasing recognition of this, the complications, sequelae, and there's a lot of work going on in the public health sphere as well around what to do with regards to this issue. So I think it's a very timely presentation. So I invite Dr. Swart to take it away.
Thanks, Dr. Tremonti, and thanks everyone for having me. I'm really happy that I could catch you all before I depart for the US. So yeah, I'll speak to you about my research that I did in nitrous oxide-induced myelo-neuropathy, which was published last year. So as you can see, there are a number of people involved in this. I actually started this research quite a few years ago while I was still an advanced trainee at St. Vincent's Hospital. And as Dr. Tremonti said, it was becoming quite a problem where we had quite a few patients who were very young coming into the neurology department being unable to walk. So very terrible presentations where they were young people who basically were doing nitrous until the point where they could no longer walk and were lying in their own kind of filth and then called the ambulance. So we decided to team up with a whole bunch of people who were also noticing these cases, so across Sydney. And then we also teamed up with a biochemist from Monash in Melbourne, just to try to make sense of the biochemistry a bit more. So it was a real team effort. So you probably all know what it looks like. This photo was taken by Professor Halmagyi, who is getting on, but he spotted this in the street and he finally knew what they were after we did this project together. So these are the nitrous oxide bulbs, and with a balloon. These bulbs are legal in most countries and you can buy them in convenience stores and online. And this amount here probably would just cost $10. The gas is delivered into that balloon and then the users inhale it and then very quickly get a pleasant empathogenic effect that then dissipates in minutes. So then they keep doing it. And because it's cheap and legal and easily bought in bulk, we think that contributes to its misuse recreationally, and it is becoming a public health issue worldwide and particularly amongst students. So this map kind of just shows that there have been case series reported across the world, Western Europe, North America, China, Taiwan, Australia and New Zealand. And it's actually been used or misused for over 2 centuries. So it was first synthesized by Joseph Priestley in 1772. And then in the 19th century, it was featured as entertainment in shows and people used it at social events and in university settings. Clinically, it started to become used as an anesthetic in 1844 in dentistry, and then in obstetrics and some neuropsychiatry applications as well. And today, the legitimate applications are widespread despite the recreational misuse. Professor Halmagyi's son is actually fast ed from Better Homes and Gardens. And he's actually obviously a chef. So he told us that in a commercial kitchen, they use actually up to 200 to 300 canisters a day. And then as the medical as we all know, it is mixed with oxygen and used for general anesthesia and during labor as well. And dentists still use it today. And yeah, so nitrous abuse amongst dentists is also recognized as well. So we know that misuse occurs worldwide. Clinically, it can cause a myelo-neuropathy, encephalopathy, or both. It presents as a subacute progressive sensory ataxia, and that's because of impaired dorsal column sensation. And nitrous oxide oxidizes B12, which irreversibly inactivates it, and then that means it can't be used as a cofactor, which is necessary for myelin synthesis. But serum B12 can actually be normal, and high serum homocysteine was a characteristic finding that we found. So we did a retrospective review and collected 20 patients altogether for hospitals across Sydney with nitrous oxide induced myelo-neuropathy diagnosed by a neurologist. And then we collected data about their clinical presentation, their blood tests, neurophysiology, their MRI, treatment and follow-up where possible. And actually, based on the suggestion of some reviewers, we then analyzed whether or not we could find any relationships between their B12 level, total and active, and then did some statistics to analyze if there was any relationship between the amount of use, the blood levels, and the severity of presentation, in particular their mobility ratings. So most of the patients were young. As I mentioned, the average age was 24, pretty even spread of males and females. And I mean, I guess Professor Hamagi was interested to see what the demographics were, because who are these sorts of people who use nitrous? And interestingly, they tended not to use other illicit drugs, just nitrous. And the use was extremely heavy, with 148 bulbs a day over 9 months. So you saw that box earlier, that was about 10, so it's a lot. And then 5 patients were supplementing B12 at the time of admission. So this table just shows the predominant clinical characteristics and examination findings. So mostly they presented with unsteadiness and paresthesias, with sensory ataxia from dorsal column loss found on examination. So in 7 of our patients, it was so severe that they were bedbound. And then other symptoms can include distal lower limb weakness, cognitive symptoms, confusion, delirium, hallucinations, and bladder symptoms. And then on examination, there's joint position and vibration loss in keeping with dorsal column dysfunction. Some patients had muscle weakness. You could get hyper or hyporeflexia, and the Babinski sign was also present in 3 patients. So this table outlines the investigations. You can see the normal results are in green, and then the abnormal values are in red. So as a group, the average B12, both serum and active, was actually normal. But if individually, there were about 10 of 20 patients who had low serum B12. And then active B12 was done in 17 patients and was low in 6 of them. But in contrast, the mean homocysteine was high at 55, and then numbers-wise, it was high in 10 out of the 12 patients who were tested. And 9 of the 20 patients had low hemoglobin, which was mostly a normocytic normochromic anemia in 6 patients. And the MRI spine was abnormal in every single patient. So the MRI shown on the right, the axial view, shows that kind of inverted V shape in the posterior column. And then the sagittal view shows the longitudinal dorsal T2 hyperintensity. And yeah, that's a characteristic finding. It can vary where it is. It was found in just the cervical cord or just the thoracic cord, or cervical and thoracic cord. And then in terms of nerve studies, most patients had a length-dependent axonal sensory motor neuropathy. So treatment-wise, all of the patients were advised to stop using nitrous oxide, and then were treated with supplementation with intramuscular B12. And the kind of regimens did vary, but mostly it was 1 milligram per day for 1 to 2 weeks, and then weekly for a month, or else monthly for 3 months. And then also adjuncts were included methionine, multivitamin, folic acid, thiamine, and also allied health, including physiotherapy, was extremely important. So this graph shows the mobility scores at admission and discharge. So at admission, you can see in blue. So 0 is, we basically created this kind of score just to try to analyze them a bit more. And 0 is bedbound or requiring a wheelchair. 1 and 2 means that they required some sort of aid. And then 3 is independent. So at admission, 7 were bedbound, 7 patients walked with some kind of aid, and then 6 patients walked independently without an aid. But then at discharge, 4 remained bedbound, 6 walked with an aid, and then 9 patients, so an improvement, walking independently without any aid. So 8 patients had some sort of follow-up, and this ranged between 1 month and 5 years after discharge. Most patients had ongoing mild symptoms, including paresthesias and gait disturbance. 2 reported continued nitrous misuse. Unfortunately, 12 of the 20 patients were lost to follow-up. In terms of notable patients that taught us a bit about prognosis, there was one 22-year-old Chinese international student who told us that he had had 2 episodes before at 17 and 19. And each of those times he said he was so severe he was bedbound back in China. And then with abstinence, treatment and rehabilitation, he had actually improved and was symptom-free between each relapse. And then this pie chart shows the outcome of 7 patients who were bedbound at presentation. So 2 were able to walk independently with crutches at discharge. 1 was able to walk with 2 people either side. 4 patients were actually just taken by their next of kin back overseas in wheelchairs. So that's why they were still bedbound. And then at 3-month, and at 3-month follow-up of these severely affected patients, 1 was walking independently, 1 with a forward walker, and 5 were lost to follow-up. And then this table shows the subgroup analysis where we split people based on their total serum B12 and active B12. So total serum B12 at the top, and just looking at any differences in age, gender, nitrous use, and their mobility scores. And basically there was no difference between the 2 groups. We didn't do this at first because I didn't think we had enough power to detect any differences, but this was on the suggestion of the reviewers, so that's what they wanted. But you can notice that with the patients with low B12, their mobility scores were worse at admission and discharge than the people with normal active B12, but not statistically significant. Then we looked for any dose-dependent relationship between how much nitrous use overall and the severity of presentation, or any relationship between how much nitrous you use and how low your B12 goes. There was no significant correlation between the 2. The red means like a negative correlation and the green is a positive correlation. So there were weak correlations where the more nitrous you use, the worse your admission mobility, the worse your total and active B12 and homocysteine, but it's not statistically significant. So this slide is particularly important in relation to B12 biochemistry. So active B12 supplies the methyl groups for protein and DNA synthesis in the cells. So if you just look at the blue things, that's active B12, and then it's taken into the cell and then is broken down by these lysosomes. So inside the cell, the cobalt chain of the B12 becomes reduced. So cobalt 3+ gets reduced to cobalt 2+ and then cobalt 1+. And then that cobalt 1+ is the thing that acts as the enzyme in two main pathways, this methionine synthase and methylmalonyl coenzyme A mutase, so in those white boxes. And then those two pathways produce methionine and succinyl-CoA. So what nitrous does is that it comes in and it oxidizes the cobalt chain. So it switches it from the green form into the blue, into the red bivalent form. So it kind of locks it there. So then it's no longer active, so it can't actually be used at a cellular level. And that's why it leads to a functional deficiency. So even though the level is normal, it's actually locked in this form that you can't use in the cells. And then that's reflected in the fact that these products kind of build up, so homocysteine and methylmalonic acid. So that's why they are high. So basically, in terms of prominent features in our population, there was a subgroup that were young university international students, predominantly from China, and they didn't take any other drugs, but they really favored using nitrous 150 canisters a day for 9 months. And actually, if you take the history, it's basically they wake up, do nitrous, have lunch maybe, do nitrous, and then maybe eat dinner, and then they go to bed. And that's how much time it takes to do that many. Whereas in the past, in the literature, it's reported mainly people's patterns were doing it at parties or shared accommodation, doing less than 10 bulbs in one sitting, less than 10 times per year. So this was kind of a new pattern of use. And I guess why are they being targeted by sellers on WeChat? What do we do about it? Another question was, why are the effects so variable between individuals? Is it the amount that they use? But then we couldn't find any particular correlation, nor was there any found in previous meta-analyses. Is it their B12 level? But up to 70% of patients with this syndrome can have normal B12, and the level hasn't actually been shown to correlate with clinical severity, which is not surprising because the B12 is functionally deactivated, so it has nothing to do with the level. We think that a more useful measure of functional B12 deficiency is homocysteine, and we thought maybe this could be useful as a follow-up marker of continued nitrous misuse, especially if the history is not forthcoming. And the data on prognosis is still limited, but in the literature, it's been shown that the clinical and radiological abnormalities can resolve after 4 months. But the most common outcome is incomplete neurological recovery. And based on our bedbound patients, abstinence in particular, B12 supplementation and allied health appear to be effective in restoring mobility. So in a young patient with subacute sensory ataxia, make sure you ask about nitrous use. And just remember, if you see their B12 is normal, that's in keeping still. It shouldn't put you off. Check the homocysteine because that should be high. And an MRI spine with high T2 signal will confirm the diagnosis. Even in the most severely affected patients, they can improve. And yes, homocysteine might be a marker at follow-up. So I just want to thank the whole team. These pictures show some key people. So Chris Blair, Dr. Sam Belitho is a neurologist at St. Vincent's. That's Professor Zong Lu from Monash, and then Professor Halmagi is here. So I just want to thank them, plus the patients and the reviewers. And thank you all for your time.
Thank you very much, Grace, and please call me Chris as well. That's a fantastic review of what is an emerging issue, and as you rightly pointed out, it is challenging because many of the patients are often international students, especially around the inner Sydney, where you've got UTS and University of Sydney and so forth, where a lot of these patients have and then unfortunately gone home. And so I think it's very challenging that we don't have as much information around prognosis. And I think that's one thing that's always very hard to talk to about patients and their families about, well, is this going to get better? So at least there's at least we're starting to get some data there. And we can start to guide our patients a little bit about things. I will have a million questions because obviously it's an area of interest to me. So please, everybody, unless you want to hear my awful nasal voice firing questions at Grace, bang, one after the other, please jump in with your questions. While we're waiting for questions to come up, I will start with a question just about delirium. I noticed in that you mentioned cognitive, I can't remember the exact word, but you had mentioned cognitive, and yeah, I must admit, I've been asked, I have seen patients who've been using nitrous who have been confused and delirious, but I've always been reticent to chalk it down to the nitrous use. And I've often, I don't simply just say, oh, it's just nitrous, don't worry about it, it'll get better. Certainly tell people to treat it seriously and look for the other cause of delirium. Is it now recognized that it's causing a delirium? If so, what's the nature of that? Is it, hypoxic brain injury? I'm not sure. Can you talk a little bit about that?
Yeah, that's definitely well described. Predominantly the presentation is this spinal cord myelo-neuropathy, but encephalopathy is definitely described from nitrous use. The mechanism is quite interesting. Like, we've kind of focused more on the myelo-neuropathy, but that I think needs to be delved into further. We could speak to our biochemist about it if she had some thoughts about what B12 does in the brain as opposed to the spinal cord. But I would say it's definitely been reported, so that the delirium can be due to the nitrous itself.
That's great to know, and certainly, look, I won't lie, I still think it's important to look for other causes, but it's good to know that we've got that there once you've kind of done that screen of looking for the basics.
Definitely.
But you don't need to go on wild goose chases of lumbar puncturing people and doing sending off Krukov's Yaxfeld's looking for prion disease or whatever else. We can kind of look for what's common, and then at the same time keep nitrous in the back of our mind as a differential for the delirium. There is a question here as well. I'll let Grace answer it, but basically treating with B12 if the serum B12 is normal. We still, answer, but I'll let Grace answer.
Oh yeah, definitely. Yeah, definitely give them B12 because the B12 level is normal, but as you saw in that slide, it's actually locked into that unusable kind of bivalent form, so it actually can't get used in the cells to make myelin, So you definitely have to treat them with B12 still, but even more so, they have to stop using nitrous. Otherwise, if you give them B12 and they keep using nitrous, it'll just keep getting inactivated.
And this might be my opportunity to brag in that with Dr. Chris Blair there, who's pictured on the screen there, we wrote a paper together about some people who were using prophylactic B12 and nagging, thinking they were not doing themselves any harm, and they were. So I think that's an important public health message to get out as well, that we unfortunately do work with a lot of people who won't change their behaviours on certain things, but I think it's very important for them to know that prophylactic B12 won't help, because it'll just be deactivated. And so, abstinence and then supplementing B12 is the necessary treatment. Just on that, I know there are more questions, but I'm gonna jump into the second one. Methionine, obviously, there's just not enough evidence to say. I tend to do it every time. Your thoughts on how much benefit it might be making?
Yeah, I mean, that was used in about 6 of our patients. Not sure how much that itself makes a difference. There was a bedbound patient who returned back to working who wasn't on methionine. So, I mean, that's reassuring that it seems to be the B12 that's making the biggest difference. But yeah, I mean, if it were my patient, I would probably just throw everything at them. Just, we don't know enough yet.
No, and I don't think there's a lot of side effect. The hardest part is sourcing it. But my understanding is that it's actually not that expensive. It just needs to be compounded, which is the hard part. So it's not actually, it's not so much a cost, it's just an availability.
Yeah, finding it.
Yeah, we don't use it for much else. There was another question then, I'll jump to this one. Is there a study which relates to the uses of nitrous oxide during birth and children born with low vitamin B12?
I didn't see any studies about birth and kind of perinatal use of nitrous and the effects on children. There were some studies done by anaesthetists who collected patients who had nitrous anesthesia and then had that provoked this myelo-neuropathy, but that was more in general kind of procedures. I didn't see anything specifically in around childbirth, but maybe that I'd have to look through the obstetric journals. I'm not sure.
No, that's okay. I think that it is important to remember this is a phenomena that the neurologist will be seeing outside of the addiction world, because unfortunately there are patients who still develop this as a consequence of anesthetics. And then of course there's pernicious anemia, and all of the B12 complications that can come from that as well. We had a comment from one which was just a thank you, and that they were just so unaware of the high levels of usage. So I think that's really great. The next question was just about withdrawal syndrome. Well, it's probably more directed at me, actually, sorry, the question, but Grace, did you want to weigh in on that first?
Oh, no, I'll leave that to you. You're the expert.
Look, in my experience, no, there's not, and I certainly haven't used any specific treatments to manage the withdrawal, as Grace, Dr. Swart has pointed out. Management is directed at the B12 deficiency. Important to get therapy going as quickly as possible to try and get those rehab goals going. We do, as I say, mentioned, use methionine as well, and whether or not that's of clinical benefit still remains to be seen, but it's still something we do and is worthwhile. So, but no, there's certainly I haven't seen anybody develop any specific to nitrous, but they may well be using other recreational substances that certainly warrant being managed, and we have seen that out in the community as well. The next question was about outside of the inner city students that we see, do we have prevalence data in rural, regional areas? Again, I might weigh in on this in a moment, but I'll let Grace jump in first.
Yeah, not that I've seen, not in Australia at least. Have you seen anything, Chris?
Yes, I work, so as mentioned, this forum involves local health districts across New South Wales, and we're fortunate enough to be joined by 4 of them, including Far West Local Health District. And I did have a patient in Broken Hill who had a prolonged hospital admission that I followed up in the aftermath. So I wasn't there when they had presented to hospital, but they had presented with the classic ataxia. They lost their proprioception and they had sensory deficits. And then I saw them in the aftermath, and they'd actually been doing quite well. But it was yeah, and I should point out this patient had other recreational substance problems, but also it was, I thought, quite telling that this is starting to have an impact in communities. And I guess another thing to add is, because they're made, it's not uncommon for over-the-counter medications or prescription medications to be quite common in regional areas, because access to illegal stuff, ironically, is a bit trickier. So it can be sometimes easier to for example, patients might use OxyContin more than they do heroin, for example. So I think it is interesting and telling that this is starting to become something we're seeing in regional areas, but certainly nothing yet, and perhaps it's something we can start to collect a little bit of data on as well. What was I going to say? Please do jump in if other people have got any questions.
I guess I could jump in just for 1 sec, Chris. Grace, nice to see you again.
Hi.
Hi. Grace and I worked together back when she was at St. Vincent's as a resident or a medical student.
It was a medical student.
Medical student. Yeah. So great to see you. Thanks for presenting today, and thanks for answering those questions. It's great. I just wondered a bit about, I know in sort of in infectious diseases with HIV prevention and the introduction of PrEP, one of the biggest communities that was left behind were Chinese speaking students who were here on visas. And so I wonder if similarly, if there's some sort of grassroots harm reduction or education campaign that's being undertaken, or if this is something that you've advocated for in publishing this work, or if there's something that we're missing there perhaps. And I just was curious if you could comment on that.
Yeah, for sure. We did talk about that in our paper, and we thought that this group would be very amenable to education and early intervention. As to how that's being carried out, I'm not sure. It seems like they are being targeted on WeChat. Chris, do you know of any kind of government higher level action that could or is being taken?
My full disclosure to everyone, I also previously worked at RPA in the drug health department there, and I still do have some research connections there. I believe, and also, so there's quite a few clinicians there who work with the Poison Centre and are very aware of this as an issue, even though it's not technically, it's not your traditional toxicological poisoning in that it's quite a chronic thing. But nonetheless, they believe that they were working with the New South Wales Ministry of Health to look at ways to manage, to look at the greater public health picture here. So I don't know if anything specifically targeting these communities has happened. They were looking around ways to regulate the sale of these products, but as Grace has already pointed out, given the sheer volume of nitrous oxide that's out there, and how necessary it is in for legitimate purposes, it's very, very hard to control. And I just don't know how as you say, perhaps that needs to be more targeted towards the users rather than looking at regulation at a public health level. It is really challenging, and I'm not sure what's out there. What was I going to say? We had a little further comment as well, that it was very popular with uni students in Wagga. when I was a student. And look, I'll add that it was also available and prevalent. I went to university in Geelong, which admittedly is not far from Melbourne. It's only an hour out of town. It's a pretty big regional centre, but still, again, yeah, availability was high. So I'll give everybody a final moment to come back with any further questions if people have them. Just while we're waiting on that, I'm one thing I just from a personal experience with a patient, there was a lot of shame just on that point about targeting to international students. I do recall quite a number of times the patient would really close up, and there was a lot of shame around this. And I really tried to emphasize that, you know, most doctors are there to help people and not judge people. And it certainly made it a challenge because there was already a language barrier to cut through. And then trying to sort of explain, I don't think you're a bad person for having done this. It certainly made it quite a challenge. So again, to your point, Krista, perhaps there's more we need to do to kind of work with the Han Chinese international students and so forth around this issue. We've had a couple of other questions come in, which was one: when was the high point in nitrous usage, or is that now? I'm assuming you mean to the questioner that, you know, as in when, like, what's the highest that levels have ever been in Australia, so to speak. So is that, or are you talking about at an individual patient level? If maybe, yeah. So I don't know. Grace, do you have any numbers around sort of at a wide level?
When I looked at it in 2019 in the Global Drug Survey, I think it was the 10th most popular, which had dropped slightly from a few years before that. I'm not sure how it's going, if it's become more popular or not, but roughly it was 10th most popular.
Well, I think that's still pretty reasonably prevalent, and as we've already sort of talked about in the chat, it is certainly just so readily and easily available. So I think this will be an issue for quite some time. There was another question about whether or not intrathecal B12 or homocysteine would be of benefit. Grace, any thoughts on that?
That's not something that has come up in the literature or anybody has ever discussed. That's very creative.
It is very creative.
Yeah. The only thing we give intrathecally now is stuff like nusinersen, which is gene therapy for spinal muscular atrophy. I don't think anybody would be really game to start intrathecal B12 or homocysteine when IV replacement seems to work. But yeah, that's an interesting thought.
Yeah, look, it is. I imagine the preparation would be one of the hardest aspects of that. Preparing intrathecal drugs can be a challenge at the best of time. And yeah, but look, it's an interesting thought. Maybe we've started something here, but I guess at the same time, we prognostically, we're not certain about. I mean,
it might scare the patients into never doing it again. Otherwise, you'll have to get a needle in your spine.
Krista's kindly shared some statistics with us. So for those of you who are interested, so from the NDHS 2019 and the previous 12 months, gradually increasing from 0.4 in 2001 to 1% in 2016, 1.7 in 2019. But this did also include, so chroming, sniffing solvents, aerosols, glue, petrol, laughing gas, whippets, nitrous numbers, poppers, quite a number of other things that have a very different risk profile and pathophysiology to nitrous. But nonetheless, it was interesting to note that there's increasing use of inhalants there. And I would imagine, well, I guess we shouldn't we perhaps shouldn't extrapolate, but nitrous would certainly be a big part of that. All right. Well, what was I going to add? The only other comment I was going to make was was very relevant. Was there was a recent mortality that involved a patient who was using a lot of nitrous. There'll obviously be further. It was only recently, and so it'd be interesting to see what was found down the track.
Yeah.
And I don't know, Grace, did you see many deaths at all? Have you seen any?
No, not really. Not really, but I did see something recently that was a patient with high homocysteine, and then in the context of nitrous use, and then they had a blood clot because high homocysteine predisposes you to thrombophilia. So that might be relevant in your patient's case.
Yes, I think just without going into too much detail, based on the nature of of how they passed away and their age and sort of the presenting complaint, I imagine that blood clot would have to be right up there. And so I guess perhaps extrapolating this further in patients who've got who've presented with syncope in the context of nitrous use, I guess it's something to keep in the back of the mind, that perhaps we need to be scanning not just their spine but their brain as well to look for potential blood clot or other things. Well, I feel like I've learned heaps today, and I should say thank you for explaining the pathophysiology to me, because I still it falls out of the mind regularly. So thank you for doing such a good job of that. But please join me in thanking Dr. Grace Swart for a really relevant and fantastic presentation on nitrous oxide induced myelopathies, and we look forward to seeing you again next week. Thanks very much.
Very welcome. Thanks for having me.
Thanks very much, Grace.